Okay, and they don't like when you dig their little jewels into their body or anything like that either. So kind of remember that. So this is a skin-on-skin contact. You're going to come in, make sure you have the proximal clavicle here at the sternum. Don't get out here. You want to actually get in to feel the joint. You feel a difference in tenderness and swelling, etc. And you're going to have the patient shrug their shoulders, nice and controlled manner, and you'll feel for them to glide. Okay, if it's not gliding down like that, the adjustment is going to be on the proximal clavicle. You're going to have the patient, if you're adjusting the left clavicle, have them take their right hand, cup their left breastplate, come through like this, make your contact here, stabilize behind the patient, watch your line of drive, bring it in this way. You don't want to be thrusting from over here, bring it here, stabilize the scapula, thrust through. Okay? If it needs torque, you just simply torque. Torque. Okay? Everybody got that? If it's gone posterior, just come in here, stabilize, just not stabilize, just palpate it. Just the way you can tell if the clavicle has moved out. You're going to abduct this. After you've abducted it, you're just simply going to extend, and you'll feel that move forward. Okay? That's all you do. You can be a little more vigorous than that. That gives you the idea. Okay, if you have problems at the AC joint, and again, these should all be on skin, stabilize this against the patient like this. And you just feel the springiness of that. Remember, you're always doing a bilateral comparison, right? Always doing a bilateral comparison. Check the good side first so that you have a baseline for the other side. Bring this up like this. Stabilize with your second metacarpal phalangeal joint. Bring the patient's arm up. Extend. Or excuse me, externally rotate. Externally rotate on this one. Okay? If it's the glenohumeral joint, you hold on to the head of the humerus, rotate it around just like this so where it gets it ready for an adjustment. Hold this in place. Supinate the patient's arm. Have the patient cup their breast. Thank you. Stabilize behind the patient with your pec on the scapula. Come up, grab the inferior portion of the elbow, and thrust this way. When you thrust, you can add some torque this way. Okay? If it's a little more inferior, maybe you have a little more I to S in your line of drive. It's a little more anterior, maybe a little more A to P in your line of drive. Okay. Scapula. So you're going to just palpate the patient. Get on the inferior medial borders of the scapula. Have the patient elevate their arms, abduct their arms all the way over their head. And you can feel the scapula rotate. Now they should rotate. How far should they rotate when she's up to 180 degrees? How far do they rotate? 60 degrees. Very good. Okay. And when she's doing that, how much are the clavicles rotating at 180? 40, 45. Very good. So you have the patient's one over here, and have you on your side, please, and face me. We're going to say Bethany's having problems with her left one. Okay. And we'll say that it is fixated in an immediately rotated position. So you can come just a little closer to me if you would. Very good. Stabilize here. We're going to pronate our patient. Bring her over like this. We're going to contact with our pisiform the medial inferior border. And I'm going to stabilize in here as much as I can with the humerus. Okay? And our thrust is going to be around this way. If it has gone lateral, let me have you lay face down, please. Have the patient's arms at their side. Remember, don't have them down on the hanging toward the floor. Have them on their side. Come up on the lateral border, and you'll see how nicely her scapula move. And you just go back and forth, picking up the difference between the two. If it has rotated laterally, we're going to push it medially. Through the fixation. Have the patient lay on their side again, if you would please. Then what we're going to do, contact the lateral inferior border with our thenar, take it back around this way, and our thrust is going to have torque this direction. If you can't get on it like that, you can bring the patient in like this, come up underneath, help you get a little better hold. Thrust over that way. Okay, how's that? Is there anything else? What happened?
Posterior shoulder dislocation.
We talked about that already, seated. I mean, we can show it prone here, you can lay face down. You don't see too many, most of it is an anterior, inferior glenohumeral joint. If it has gone posterior, you can just take this into position, add some internal rotation and adjust it just straight down. So you can see I'm adding some I to S in there, not just all P to A. Or, excuse me, S to I, not all P to A. Okay? And there's all kinds of ways to move these bones. You should be looking up a whole lot of different sources just to see how they do it. Because there's some pretty cool stuff out there. You see things that you like better than the way we do it, let me know. I mean that, let me know. The ulnar humeral joint, this is where you're going to motion palpate this. Just nice and easy. Bring it into full extension. That's all I want you to do. Arm supinated, hand on top. I don't want you like this. Why don't I want you like this?
You can slip out.
You can slip out. You know, they say that, your dad was a policeman, right? They say that if somebody ever grabs you to go somewhere and you don't want to go with them, you always break out on their thumb side. Did you know that? Yeah, so like if I grab the hold of her, she should try to get out this way instead of this way, because the thumb is weaker. And so if you're like this, there's a chance when you make your adjustment, you might just slip. You don't want that. Your patients want you to be in control. They want to know that you know what you're doing. Okay? If you're just fumbling around, they're not going to have much confidence in you. So just hold the hand like this, fully supinated, and just move it up and down. You can hold it like this. You can hold it like this. You can use a marble shooter's grip. Right? You do your bilateral comparison, and you're feeling for what?
Bony end feel.
A bony end feels what you want. If it's a problem, what are we going to feel? It's going to be spongy in there. Okay, it's not going to settle as nice and clean as the other one. If it's not, then what you're going to do is you're going to take your thenar, put it right up underneath the chromium process, and your line of drive is going to be basically P to A. Okay, take out your slack and thrust through. You can again use your thenar, you can use this type of a grip, or you can use your marble shooter's grip. And remember, it is not a scissor move, just take out your slack, thrust. Okay? It's a nice, brisk, shallow thrust into audible, and the patient will be happy. Okay? If you have a problem here with the radial, this can also go medial or lateral. Motion palpation is pretty much the same. If it's medial and you're standing laterally, then just use your fingertips, come up underneath here. Again, keep this supinated and give it not just the P to A thrust, but a little bit of medial to lateral thrust, like this, right? Or you can stand on the inside and use your thenar. Just like I'm going to do here, if it's gone a little bit lateral, I'll use my thenar here, come up under this way, and I'll add just a little bit of lateral to medial with my P to A, this way, okay? Radial head. Usually goes posterior and lateral. You motion palpate it just by fully supinating and pronating the patient's elbow. Okay? Fully supinating and pronating. If you're going to adjust it, keep the patient's arm supinated, bring it down at their side, switch over your thumb to your marble shooter's grip right here, and the line of drive is going to be P to A and lateral to medial, right there. Okay? And that's all it's going to be on the test.